My name is Danielle Rahajasan, and on behalf of the National Center for Medical Legal Partnership and our panelists, I wanted to thank you for taking time out of your very busy schedules to attend this event today. We are very excited to welcome you to the first of a four-part session learning collaborative titled Using Legal Services as Part of a Community Strategy to Improve Maternal Health in Health Centers. Next slide, please. In just a moment, I will turn this presentation over to our panelists, but before that, I have a few small housekeeping things I would like to run through with everyone. Everyone did join in on mute. However, we do encourage you to unmute yourselves to post any questions during the discussion session and throughout the collaborative. We are using Zoom for our event today. If you have questions, please type and send those in the chat so that panelists can see them and can connect with you. If you would like to activate captions, please select captions, then show captions on your toolbar, which should appear on the bottom or at the top of your screen. And yes, today's audio recording and slides will be made available to participants by early next week on the resources pane of our website. Again, today's audio recording and slides will be shared with all of you by early next week. And if you have any questions, please don't hesitate to use the chat function to pose them during the didactic portion of this session. Next slide, please. We also want to acknowledge that this project is made possible with the generous support of the Health Resources and Services Administration, and that contents are those of the authors and don't necessarily represent the official views of or are not an endorsement by HRSA, HHS, or the US government. Next slide, please. So like I mentioned in my initial introduction, this is a four-part learning collaborative that will focus on how the medical legal partnership approach can align with health center priorities or your organization's priorities to help improve maternal health in our communities. Last year, some of you may have attended our first session of this first edition, of this learning collaborative that focus on both maternal and child health. And this year we really will be focusing our energy and exploring strategies to integrate legal services as part of your clinical practice to address maternal, social, and legal needs. The sessions are all 90-minute long, and will include short didactic sections coupled with guided discussions in the form of breakouts or other methods. Essentially, this cohort will meet every Wednesday in March. So March 1st, 8th, 15th, and 22nd. And during every session, participants will hear from faculty as they discuss their MLP models and share learnings around strategies and from their own successes and challenges when developing a maternal health focused MLP. Panelists will also help us moderate discussion sessions where you get to engage with your peers and faculty as well. We do know that we have a mixed cohort here in terms of organization types, MLP familiarity, and whether you're newer to the approach or have an advanced MLP. There will be something here for everyone, as this collaborative was designed to really meet you where you are. This is a collaborative learning, so we really do encourage you to interact and engage with your peers so that we can have a rich discussion around our topic. And please don't hesitate to ask any questions and share ideas and practices, especially during the discussion or breakout sessions. Next slide, please. So for today's session, we're going to look at the collaborative objectives, introduce speakers and panelists, hear from the latter as they have prepared pertinent and useful content and resources for everyone today. Then we'll go into the guided discussion portion of the session and close out. Next slide, please. So throughout the collaborative, our objectives are to make sure that participants will understand MLPs and their role in maternal health, understand how to detect and address unmet legal needs that negatively impact maternal health outcomes, and finally develop strategies to collaborate across health and legal settings for integrating civil legal services with your health center's maternal priorities. Next slide, please. We're joined today by an amazing group of experts, and we want to reiterate our thank you to them for agreeing to work with us on this project. You will get to know them a lot more throughout this collaborative, and you also should have received a welcome packet that was sent to you by the NCEMLP team, which is a document essentially that includes the collaborative structure, the learning objectives, panelist bios, as well as important resources to support your learning and discussions during this collaborative. If you want to learn more about these individuals and the work that they do, please consider as well. So very quickly in session 1, we will be joined by Amanda Ilkanik-Oder and Bronwyn Blake from Texas Advocacy Project. Session 2 will be led by Courtney Mendoza from Mental Health Advocacy Services. Session 3 by Nola Booth from Legal Assistance of Western New York or Law New York. And you see here some familiar faces from last year's collaborative: Vicki Gerard, Loral Patchen, and Roxana Richardson from Georgetown University's Health Justice Alliance will lead session 4. Next slide, please. We're also very, very excited to hear from today's special guest, John Richards, who is the Executive Director for the National Center for Education in Maternal and Child Health at Georgetown University, to help us introduce and set the tone of the collaborative today. Next slide, please. Before I pass it on to John, though, I want to make sure that we get to know this cohort, that we get to know each other, and this cohort of learners as well as upstreamists. So if you can use the chat function to write in your name, title, the organization that you work for and its location, and also answer the question, what is at the top of your bucket list this year, while I pass it on to John. So John, it's all yours.
Wonderful. Thank you so much. This is such a treat. And I have to say, when I was asked to present, I thought, oh my gosh, what am I going to talk about? And then I realized, how can I possibly limit myself to 10 minutes? So I want to give you a very quick overview of some of the supports that are available from the federal level down to the administrative level and down to a university level, and talk about the needs that we are seeing as they affect women and mothers across the country. So next slide, please. We're going to jump right into it. And if we start at the top level, my good friend Kay Johnson had put this together, and I want to share from the top level of our government, the Biden-Harris White House blueprint. This is not new, and it's lofty. And will we make it in any amount of time that in our lifetimes? I don't know, but what I'm so excited to see is that we are moving beyond just our traditional health that we talk about into behavioral health, into oral health, into those structural and societal drivers of health, all of the things that are moving beyond our comfort zone when we are thinking of the work we do funded by HRSA. So on the left, you see the charge on our goals, and on the right, you see my center, the National Center for Education and NCEMCH. And we've been at Georgetown we just celebrated our 40th anniversary working in the field, and I've been here 25 of those 40 years. The 3 projects that we really focus on, and this is sort of we are standing on the shoulders of giants who've done this work from the Children's Bureau on down. And I just wanted to give you all a sense of what the needs are and what the supports are outside of the silo of BPIC that we're trying to break those silos down a little bit. So moving on to the next slide here, I want to just give you a sense. So the U.S. Maternal and Child Health Bureau is where I actually receive my funding for all of our centers, and the work that so many of you do through the Bureau of Primary Health Care. We do work hand in hand. It is not an empty gesture that there is synergy. But just to give you a quick sense, because you might not know everything that Title V does out of the Social Security Act to assist women, specifically those who are expectant mothers. You can see here on the left, currently 92% of all women in this country, pregnant women, are covered by Title V in some way, shape, or form, either through block grant funding that goes directly to states and jurisdictions who can then use that money as they deem fit, to address the needs of specific populations, but also through what we call the SPRANS grants. These are the special projects of regional and national significance, like here at Georgetown. So you can see we Title V serves a lot of pregnant women, almost all of infants under 1 year, and then you can kind of see how this plays out. In particular, if you look on the right-hand side, these are 15 topic areas, and I know they're a little small. I hope you can see in the slides. Everything from the well woman visit, we move through women's health. Well woman, we look at cesarean birth, we look at perinatal regionalization, then into infancy, breastfeeding, safe sleep, developmental screening, all the way through, we're growing up as we go down the list, our early childhood, middle childhood, and then like some cross-cutting issues with medical home, with insurance, with smoking, with oral health. So these are all areas that we see movement in for maternal health here. So moving on to the next slide, I know I'm giving you a whirlwind trip here. Title V loves data all the time. But I will say, so of the 7 national performance measures, some of which I just talked about, from looking at the well woman visit all the way to adequate insurance coverage, we have data, national data from 6 out of those 7 measures. And you can kind of see it doesn't take a rocket scientist to look at this and say, oh my God, where are we going? And I hate to say it, the answer is kind of nowhere fast. Don't quote me on that, but you look, we have plateaued a lot in, while some of these are, they're not bad, but there is definite room for improvement. So pretty much across the board, I think we can make improvements, and we're working towards that. So next slide, we'll move beyond the bad news. Let's talk about the good news. I love to talk about conceptual models because I do think conceptual models give us the framework to make impact. So here at the MCH Evidence Center, so mchevidence.org, we try at Georgetown to look at those strategies that have the most potential to affect change in all of those 15 national performance measure topic areas. So starting with well woman care, all the way to making sure that everyone is continuously and adequately insured. And we look at, well, let's look at the conceptual model. We start with the evidence base. We know that if we look at what studies have been done, what research has been done, and aggregate that, we can find those strategies that have the most potential to elicit that change. Science alone is not enough. We know that we need planning processes to make sure that this happens on a state level, on a community level. So here at Georgetown, we push a planning process called results-based accountability, which is just training you to look at the data, deciding, is this data good or not, just like we did in the last slide, and let's start to brainstorm on ways to think about addressing it. And then looking at everything through an equity lens. So on the right-hand side here, you see my lovely little circle logo of MCH Best. This is our bank of evidence-based strategies and tools. This is our one-stop shop for, I think at this point, we have about 1,500 peer-reviewed journal studies, and we've looked at over 100,000 studies to identify what works, for whom, and under what circumstances. So if you move to the next slide, here, I just wanted to give you a sense of the type of work that we do. So if we're looking at the well woman visit, how do we get more expectant moms into the well woman visit, and women in general? We can see that on the left-hand side, we have a sense of, this is what the science says. We always start with the science. This slide is incredibly deceptive because we have a list of, let's say, there are 15 strategies that we have found to be successful in multiple situations. If you click on each one of these, and if you go to the website that was on the last page, you can see that there is a wealth of information. So one link takes you to where you can see what is the evidence behind this, even accessing those peer-reviewed journals. Who are the experts in the field? Who can I contact if I'm looking to increase the well woman visit in my community? what are other states doing, both at a state level and at a community level. And then on the right-hand side, you can see the emerging practices. These are those programs in the states right now in community levels. Like you can see, here's one from Minnesota, Oklahoma, New York. There are 3 really promising practices for increasing that number of women going into the well woman visit. So always start with the science. Next slide, please. This is just sort of a visualization of the type of resources that you can get when you click on those links. We go into the background. We also give you examples of, it's really good to set up a program, but we have to be able to measure that we have impact. So on the right-hand side, we always feel that measurement and evaluation are hand in hand. So it's a one-stop shop. When we talk about science, it's, I hate to say it, but cradle to grave. When, you know, looking at the data, looking at the science, and looking how do we implement and measure those programs that we are conducting. Next slide. Like I said, science alone is not enough. So here we also, and at the top, you see a nice little link here that goes about a process of what we call turning the curve. All of those charts that I showed you on the second slide, they were really kind of sad. And without intervention, we call this the cost of doing nothing. We probably imagine that line to keep going flat like this. We want to increase that. How do we turn the curve? This planning process that is really equity-based really has 2 tools that have been developed and have been used really across many states for, I would say, about 20 years. It started in the child welfare world, and we've been moving it into the Title V world for children and mothers. So the Evidence Center website up there has all these great planning tools. And the amazing thing is, we're not talking rocket science. This is all stuff that everyone is doing. Every health center is already doing this, whether it's in PDSA cycles, in however it's planned. This is just putting steps to it to make sure we're not forgetting anything. All right, next slide. And then finally, we always try to, with everything, look through an equity lens. So at the left, you see we use the Hayes model to make sure that we're not forgetting anything. The one tool that I always say have people work on is the tool from NERN out of the University of North Carolina. It's called the hexagon tool. And that sort of wraps everything up, looking at the need, looking at what the evidence is. And you can kind of see in this hexagon, these 6 areas. You look at the need, then you look at the evidence. You look at usability, and then you look at the fit. You look at the supports that you need, and then you look at the capacity. So it's a going back and forth, sort of a bilateral way of looking at a program that you have to see, is this going to work? Does it fit with the evidence? Does it match our need? The nice thing about the hexagon tool, and you can access it from our tool page here, is that it's a 6-page worksheet, and it literally guides you through each program that you're working, and you can kind of score your programs to say, okay, how is this one working? Well, let's look at it against other programs. And it's a really good way to fit your resources into what you're going to do at any levels, from the community level all the way on up. I will say on this page, I'm sort of a used car salesman here. There are a number of health equity tools. We've gone through, oh my gosh, probably 1,000 health equity tools over the years. And we've really kept it down to the top 12 to 15 tools that we can use, that can be used in the field to look at data through an equitable lens, to develop programs through an equitable lens, all the way to implementing and measuring them. So next slide, and I'll wrap up real quickly. Again, just saying, on the right, I did take some time before this call to actually look at what the needs that we saw through the states and through the communities. And they're sort of organized here on the left, and they're everything from mortality to oral health to development to behavior, well woman care, substance use, everything that you know are the sticking points. On the right-hand side, I did want to say a great resource, and I want to leave you with this, and it's a passion of mine. It is the NCEMCH Digital Library. And we have at Georgetown been collecting these resources. They start back in 1912 with the foundation of the Children's Bureau. and they go up to the current moment. Every day we add more resources as they are developed. And I would say any of the topic areas that you are working on, if you need background information, go to the NCEMCH Digital Library. It is your one-stop shop to find those resources that you can use pretty much in everything that you're doing. I know I went a little over, but I hope I at least set the stage to let you know that you are not alone out here. There are other agencies, there are other little think tanks all around the country working hand in hand with you, and we are a resource to help you through this learning collaborative, but beyond. So thank you so much for this time.
Thank you so much, Sean, for setting the tone, for getting us excited about this opportunity, for sharing all of these important resources with us, and reminding us to always start with the science and the data when implementing programs that are evidence-based, such as the MLP approach, and to always look through the equity lens when you look at the evidence. So to move us further along, I will now pass it on to a panelist member, Loral Patchen from Georgetown Health Alliance, Health Justice Alliance. Loral?
Excuse me. Hello, everyone. I just wanted to share a little bit about why we started our MLP and how it has been particularly effective in our MCH setting. There's been a real push, appropriately so, over the last several years for providers to engage more around social determinants of health, because we are beginning to understand how important they are for outcomes. And it's often a very big ask, because as a provider, if you ask about something, you're trained to have that you need to respond and follow up. And many of the social determinants speak to areas where we are not experts. So as we've started to ask more questions around housing security, food insecurity, et cetera, it became very evident that we needed to also figure out how to respond in a way that was going to be meaningful and impactful for patients. And that's sort of thinking and the challenge of providers wanting to lean in terms of recognizing the importance, but also feeling like if we were going to ask these questions, we needed to have a response that would help support patients in problem solving their challenges. And our MLP has been extremely effective in that. Perhaps the biggest benefit in some ways to establishing the MLP has been sort of removing the fear within the clinical team of asking some of the hard questions around context and the context that matters for health outcomes. And it's been great to have it in place as we've started to see over the last couple of years that more and more evidence is starting to surface around eviction and the risk of preterm birth. And we will, I think, continue to see more studies come forward that are beginning to explore and establish the connection between the social determinants that we all care very much about and the impact on health outcomes.
Thank you so much, Loral, for setting the tone and helping us kick off this collaborative. So I'm going to go through a couple of slides that will talk about the MLP approach very broadly, because there are a few people in our cohort today who are newer to the approach, and so we want to make sure that we are level setting with everyone, and also because our panelists today will discuss their models in greater detail. Next slide, please. So MLPs have been around for over 25 years. It's not something new per se, but something definitely to be thought of more and more as normative in our healthcare system. So medical legal partnership is an intervention where legal and healthcare professionals collaborate to help patients resolve social, economic, and environmental factors that contribute to health disparities and have remedy in civil law. You can find this definition on our website, but it's essentially embedding lawyers into the healthcare team. These lawyers help improve the health of communities, build a stronger workforce, and improve health equity through 4 different levels that represent the upstream approach. First, there is the bread and butter of the MLP approach, which is the direct legal advice, patient level of care, where the lawyers help the patient with their social and legal needs so that the healthcare workforce can operate at the top of their license. Then there is the operational level where training received builds capacity and strengthens the health center or hospital or any other organization's workforce to better address the social determinants of health. Then at the institutional or clinic level, lawyers can help shape clinical practices to address patient needs, which will then hopefully lead to policy changes at the community level where MLP use the upstream strategies to target unhealthy policies to prevent future problems and advance health equity. Next slide, please. So where do legal services fit within the health center's response to the social determinants of health in general? This graphic was taken from the MLPs in Health Center Toolkit, which is a resource you will find in your welcome packet, as well as the National Center for Medical Legal Partnerships website. So we do invite you to peruse that document, as well as other resources on our website to learn more about the approach. So the World Health Organization defines the social determinants of health broadly as the conditions in which people are born, grow, work, live, and age. Social needs are the more immediate needs that the patients present to their providers as a result of social determinants of health. And legal needs are the subset of social needs that have legal solutions. So for example, Danielle, who has 2 kids and is pregnant with her third, lives and has been living in a food desert for some time. She, as an individual, especially being pregnant, needs healthy food, such as produce to sustain a healthy pregnancy. Danielle enters the health center for a checkup and is told that her baby and her other children are underweight. The doctor uses their social screener to determine if Danielle's social needs have legal solutions. The doctor finds out from the screening that Danielle's SNAP benefits, for instance, have been incorrectly cut. So she is referred to a lawyer who can file an appeal to address that and get Danielle's benefit back. So MLPs will work with different entities such as social workers, providers, public defenders to screen and refer patients and address their civil, legal needs and healthcare needs alike. Next slide, please. So without further ado, I'm now going to invite Amanda Elkanik, who is the VP of Advocacy and Outreach at Texas Advocacy Project, and Brennan Blake, who is the Chief Legal Officer at Texas Advocacy Project, to discuss their maternal health MLP model. All yours, team.
Thank you so much, Danielle. I am Brahma Blake. We're going to pull our slides back up, but I have been working at the Texas Advocacy Project as an employee for 18 years and clerked there and volunteered there before then. So I'm a super fan of Texas Advocacy Project. And I'm looking forward to telling you a little bit more about our organization, but I also want to introduce my co-presenter here, Amanda Elkanik-Oder. Amanda, I'll let you say hi.
Hi, everyone. Can y'all see me?
We could a second ago, and then you faded to black, but you'll see her smiling face again in a second. And Amanda's been working in the movement for as long as I have, and has been at Texas Advocacy Project for many years now. So when we have the slides back up, we'll advance to the next one, and you'll see a summary of what I'm about to tell you, because I just want to paint a little bit of a picture about what our organization does, because in the MLP world we're the L, and I know some of you in this cohort are the M and some are the L, and I just want to say hello to all the L's out there. Say hi. But we are a nonprofit law firm, essentially, and we've been providing free legal services throughout the entire state of Texas for 41 years now. And we really specialize in a boutique way on interpersonal violence. So we take a very expansive view of that. You know, it's not just domestic violence, any kind of power-based abuse, including child abuse and human trafficking. This is the world we work in. Any kind of civil legal solution that these survivors might need, we want to work to help them. So our office is in Austin, Texas, but we have employees all over the state, like Amanda is in the greater Houston area. And we're not just providing legal services now. We also have training and outreach and advocacy work. So we're just, always getting bigger over here at TAP. Everything's bigger in Texas, right? So a little bit about who we help. We, year after year, we're serving, closing up almost 5,000 cases a year. And that means we're helping over 10,000 victims every year, because a lot of our clients have children. And so when Amanda and I started talking more about medical legal partnerships and what made sense with our population, I think you can see it's a natural fit for talking about maternal health. And we have a short, if you'll advance the slide, this is just a short little summary of some of the stats I was sharing with you about our great work. And this, you can see here the case number and the number of clients. It's a little bittersweet because when we're talking about survivors, that there are a lot of children in that number, a lot of babies and children in that number. So Amanda, I'd love you to play the PSA on the next slide so people can learn a little bit more about TAP, and then we'll dig into the subject of the day.
What is your emergency?
No! Stop! Stop it!
He dragged me by my hair across the living room floor. He tried to break both of my arms.
I feel like my children were ripped from me.
He had told me he would hurt my little brother, he would hurt my mom.
My attorney with the Texas Advocacy Project was able to help me find out strategies and things that we could do in order for me to see my children again.
My attorney helped my daughter to receive a lifelong sexual assault protective order against her abuser, my ex-husband.
As a human trafficking survivor, my past victimization was used against me by my job. No one would help me until I found Texas Advocacy Project. They helped me find my voice again.
I was awarded sole conservatorship. That is the single most important thing that's happened in my life. My son and I are safe today because of Texas Advocacy Project.
Thank you, Amanda. I will now turn it over to Amanda so I can stop talking about clients and we can start talking about patients.
Maybe we'll see. Hold on. It's
Spoiler alert, everyone, they are the same people. So I think you guys know that. And Amanda's gonna
there we go.
Into why they overlap.
Okay. Hi guys. Sorry about that. While we were getting started, some random person just tried to walk into my house. So I don't know what that was about, but all good now. I'm Amanda. I'm the Vice President of Advocacy and Outreach at Texas Advocacy Project, and I have been working with survivors here in Texas and nationally for the past 16 years in lots of different ways. So I've worked in domestic violence shelters and rape crisis centers. I've helped with some legal policy at our state coalition, and 8 years ago came to the Texas Advocacy Project to help grow the advocacy and outreach arm of our agency. And through growing that advocacy and outreach arm, Bronwyn and I have been partners in crime, is what we call ourselves, in providing information and trying to figure out where survivors are intersecting. And we're going to go into specifically around survivors and how they might be intersecting within your healthcare systems, because we know that a large portion of survivors will access healthcare services, and it's important for our systems to be set up with appropriate screening and safety planning and referral networks. So let's first start by just laying the foundation. So how often does intimate partner violence happen? We can tell you that we're here in Texas. You heard earlier, everything's bigger here in Texas. And so are the numbers of survivors that we serve. And so we see that about 1 in 3 women will experience intimate partner violence or know somebody who's experienced intimate partner violence in their lifetime. And with the pandemic, the COVID-19 pandemic, we saw that these numbers were steadily increasing with increased tensions within homes, loss of jobs, instability within systems. We knew that we were probably going to see survivors have a lack of access to resources within their communities because they were stuck in homes with their abusers, and they weren't able to access those resources in a safe way. We also saw that a lot of survivors might have foregone going to their normal check-ins with their healthcare providers during that time as well. So it became increasingly important for the partnerships that we had created before the pandemic to have these integrated services within their systems. But why we're all here today is to talk about maternal health. And what we know is that about 324,000 pregnant women are affected by intimate partner violence each year. There was a maternal health, maternal mortality morbidity report that was released earlier this year here in Texas. And so I'd like to offer you to go and dig into your own states and see what types of research and statistics are being shared amongst maternal health and morbidity within your states. But I want to point out one of the key statistics and findings of that report. What they found is that 1/4 of the maternal morbidity deaths in Texas were related to violence. So we know that that is a huge number out of all of the deaths that could have been prevented. And so for us, this causes an even more urgent need for healthcare partners to partner with legal service providers, and specifically in this specialty service of legal services, where we are attorneys on staff. We have 17 attorneys on staff across the state that can provide life-saving legal services like protective orders. And Bronwyn's going to go into all of those types of legal services that her amazing team is able to offer, but making sure that we're really wrapping those survivors in services and serving them holistically is really important. Another research study that came out a number of years ago by some of our partners at the University of Texas medical branch and the Center on Violence Prevention found that only about 10 to 15% of survivors will ever access traditional services through family violence centers. So that's like your domestic violence shelters, your outreach centers, and your communities, 10 to 15%. So when we look back at the numbers that we just showed on the previous slides, we know that there's an overwhelming need for education, information, and resource sharing amongst partners that are not those family violence centers, but also connection with those family violence centers because they're also able to provide life-saving services like shelter. So this is where Bronwyn and I come in and really looking at the systems-based advocacy that we provide and what systems do survivors access. And during pregnancy, you have approximately 1 billion healthcare appointments, right? Especially towards the end, and you're developing strong relationship with your providers. And this is a really intimate time and unique time in building that relationship with a patient that might actually solicit disclosure of abuse that they might be experiencing within their homes. This is me and Bronwyn's favorite picture. So fun fact, we have daughters that are 6 years old now, and they were born 1 day apart in the same hospital. And I always give this, I call it a fun story. You can decide what it is to you.
It's fun.
So, I was really lucky in the fact that I had a doula, I had a midwife and a healthcare team, and I was able to deliver at one of the best hospitals in the Central Texas area. And while I was in labor at the hospital and I'm pacing around the hospital room, my doula is providing support to me. one of the hospital nurses comes into my room and she has a clipboard in her hand and she's asking me a list of questions. And one of the questions that she asks me is, do you feel safe at home? And my husband was standing right next to me. And I was like, oh my God, thank you so much for asking me this question. And she kind of went pale and looked really mortified and she didn't know how to respond to that question. And I was like, oh my God, you just don't understand. Like, this is what I do for a living. And oh my God, but what would you have said if I said no? And my husband's right next to me. So fun fact, it was her first day on the job. So I'm sure that that is ingrained into her memory, one of her core memories for the rest of her life. But that it's a valid question. My husband was standing right next to me. My husband's standing next to me the whole time going, Jesus, Amanda, this is not a training opportunity. We are literally about to give birth to our daughter, right? And I was like, oh, okay, yeah. Let's talk afterwards. Did we talk afterwards? We absolutely did not, because having a child is a very traumatic experience to your body. And I completely forgot about responding to her in a different way later. But that is a really important time for us to have these conversations, right? And to make sure that we're doing it in a trauma-informed way, and in a safe way as well for your healthcare providers on your team, and also for the survivors that might need these services. So let's talk about some of the health consequences of abuse and trauma. We know that abuse and trauma have both short-term and long-term health consequences. I'm sure that everybody on this call is familiar with ACEs and the adverse childhood experiences studies that have been done and the statistics around that. And we know that, the short-term effects of abuse and trauma can be increased rates of anxiety and depression. But what we're really looking at in the work that we do and honing into this perinatal space is, what are those maternal mortality rates? What are those short and long-term effects on pregnancy? What are the effects of having, early birth or loss of pregnancy? How are those survivors getting pregnant in the first place? Has their abuser, limited their use of birth control or lied about their own use of birth control to get them pregnant in the first place? And when we're really looking at training and partnering with healthcare professionals, we really want for them to see that there's lots of different health consequences that abuse and trauma have on survivors, and specifically on survivors who are in such a vulnerable place because of pregnancy.
Amanda, I know in the past we've drilled down more on some of these and talked about, under reproductive health, like you said, it could be an unwanted pregnancy. Interpersonal violence can lead to miscarriage. Under physical health, obviously injuries. Under chronic illness, we could talk about fibromyalgia can be caused by abuse. Under mental health, you've got depression. There, all of these little boxes at the bottom can be drilled down even further. So there's just a myriad of health consequences out there.
Yeah, absolutely. This is a little blurry, so sorry about that. You heard a little bit about social determinants of health earlier in our presentation today. And we know research shows that a person's health is determined by their environment, where someone lives, works, plays, and learns. 60% of their health is determined by these social determinants of health. So we know that social issues are legal issues. These are the 5 most common types. You'll see income and health insurance, housing and utilities, education and employment, legal status, and personal and family stability. Bronwyn mentioned earlier at the top of our time today that, one of the unique things about Texas Advocacy Project is we don't have any barriers on our services. We're statewide. We don't have any barriers on recency and violence, on income status, or on immigration status. And that's a really important factor that we have to ensure is, in what ways is our own systems creating barriers for survivors? And what ways are the agencies that we're working with have barriers? And then how can we fill those gaps? And what partners can we bring in to help fill those gaps so that we can meet each of these social determinants of health to wrap those survivors holistically in services. So now let's move on to screening and best practices to integrate into your practice. We're going to have some time at the end of our presentation to learn about ways that you guys might already be screening. And we're going to give some of the best practices by some really amazing national organizations like Futures Without Violence have created, and the Center on Disease Control. But we want to learn from each other. This time that we have, this cohort, these peers that are in this room with you today, let's learn from each other. Let's not recreate the wheels. Let's try to figure out how have other people broken down barriers and been able to integrate these services into their practices. So here are a few things that we found are really key, and these are also directives that have been given by the Center on Disease Control as well. So the first thing is healthcare providers are trained on recognizing abuse within their clinic, trained on how to create standard operating procedures, and that they're in place and everybody's trained on what those standard operating procedures are, that consultations take place in a private setting. I don't know if any of you work for a clinic or maybe you've been to an urgent care in the past, that you go use the restroom and maybe there's a sign in the restroom, or maybe you have to leave a urine sample and there it says, write on this urine sample in black if you're a victim of domestic violence, and then they'll, make sure to let the healthcare provider know. There's lots of different ways that you can integrate some practices within your model. But consultation taking place in a private setting is really paramount to survivor safety. Like the example I gave you earlier, I'm in the middle of giving birth to my daughter and my nurse comes in and my husband's standing right there. That wasn't a private setting, right? And even if I was in an abusive relationship, I wouldn't say that I was, because that could actually cause me to be in a more dangerous situation later. Confidentiality is guaranteed. Listen, attorneys love privacy. They're really key on their privilege and being able to have free, confidential conversations, right? And the same with healthcare providers, lots of HIPAA standards. And so there's a lot of synergy in the privacy related to patient care within both of these models. A referral system that's in place to ensure that patients can access related services. The National Center for Medical Legal Partnership has some really great best practices on how to integrate legal service providers within your model. And the referral process of that is just the tip, right? Being fully integrated, having built trust amongst teams, those legal providers being able to come into the clinics and provide legal services is really key to it. So whereas having a handy, one pager or a pocket card that has, an agency's phone number on it is great. But I want to invite you for a moment to think about if you were a survivor living in an abusive relationship and you went to your healthcare center and you disclosed that you were in an abusive situation, but you weren't ready to leave that abusive situation yet, right? Maybe you're just in the information gathering stage. What can you do if you are ready to leave, right? And maybe you give somebody a safety planning brochure. Listen, we make those brochures. So we love them. We give them to partners all the time. But if you receive that as a survivor and you have to go back home to that abusive partner, do you think that you're going to take that safety planning brochure with you? Probably not, right? Your abuser might say, what is this? What did you tell people? It might actually cause another abusive situation. So understanding how to make a warm referral. I love to call them like a hot referral, like a hot potato, because I want to know the partners. I want to be able to call Martina and say, Martina, I have a survivor who's in need of services. Can you help? And she says, yes, can I call her? Right. And Martina picks up the phone and calls her. So we're breaking down those barriers of giving another number for a survivor to have to call. Healthcare settings are equipped to provide a comprehensive response, addressing both physical and mental consequences, and healthcare providers gather forensic evidence when needed. This is an expansion of our medical legal partnerships that Bronwyn and I are looking at right now, is how can we have integrated legal services within forensic nursing clinics here in the state of Texas? So understanding these access points, understanding what your internal policies are, how to look at that from an equity lens, how to look at that from the social determinants of health lens, and build the relationships. It's a key part of really strong medical legal partnerships is the partnership piece of it.
Guys, I just have to pause for a second because hidden in Amanda's amazing acting with her skit of calling one of our healthcare partners, Martina, was a best practice that Amanda has implemented a Texas advocacy project, and that's we cross-refer with our health partners. So we're sending survivors of intimate partner violence to our clients to become patients of our healthcare partners just as much as they're sending their patients to become our clients. So that was a big watershed moment for me when Amanda started doing that. And honestly, I think it makes the relationship stronger.
Yeah, absolutely. Well, we have a case study at the end of this presentation that kind of goes into that cross referral as well. On your screen, you'll see this was the World Health Organization released a report on the health consequences of intimate partner violence on women's health. And so what you see on maybe the left side of your screen is physical. And so this is going to be where you have patients coming in because they have physical injuries related to violence. And these patients may have already come into your practices. You may have intersected with these survivors. But what I really want to look at is the way that trauma comes out in other ways in the maternal health aspect. So the sexual and reproductive, having access to meaningful health providers, healthcare providers, to help look at all of the different issues that a survivor of intimate partner violence might be facing. So increased blood pressure, chronic pelvic infections, pregnancy-related complications and miscarriage. This is one of the things that we started tracking just within the last 2 years, is how many survivors that were accessing our services, our legal services. We started asking, are you currently pregnant, or have you recently had a child or had a miscarriage? And that was a really important question for us to start asking, because as we're looking at some of these issues, we might not be capturing miscarriages related to violence as well. So this is, I mean, there's so many tools out there to show the effects that abuse and trauma cause on pregnancy. And we have all of these resources linked, and we can put them in the chat box for you as well, so that you can dive into them a little bit more deeply. We have a quick video that was actually created by our partners out of Futures Without Violence. And you might be sitting at this point of the presentation saying, okay, this is great, Amanda and Bronwyn, but like, how, as a healthcare provider, what do we do? How do we ask these questions? How do we follow up? And so we're going to show you a quick video on what that might look like. Should we try to play it, or Danielle, should I stop sharing and let you play it?
Either works. I can play it for you if
okay, let's just, yeah.
Try? Okay. I'll give you a thumbs up.
There we go.
I don't think we have the sound.
We can't hear it, Danielle.
I think Danielle will restart that video with the sound. You know, when you share the screen, it asks, do you want to play video sound, right? I always forget that. I noticed we had a great comment from Kayla from Waco about how you might see one of the medical indications from the last peachy colored slide, but that might be the first time you're observing something that could indicate intimate partner violence. And that person might not be ready to, you know, take a legal referral or leave an abusive relationship at that time, but being cognizant of observing that these could be red flags of abuse can help you start that conversation. So I think Kayla's comment was great. And I encourage all of y'all to make comments while we're presenting so we can, keep this conversation going.
I thought you were supposed to get us the good sandwiches.
I'm sorry, these are not more exciting. Clinic ran late.
That's okay.
Hey, remember those patient satisfaction scores? They're beginning to matter more and more to the powers that be. And this is awkward, but they asked me to give you some pointers. It's really hard for me because I think you're an amazing clinician and I really respect your work.
No, I appreciate it. I know your scores are always so good. It's a little... Okay. It's frustrating because I'm really conscientious.
I know you are. The patient scoring thing is not as much about medicine. It's about how the patient feels. It's much more simple to have the patient feel connected than you might realize. Like, I really make eye contact on the hard questions. When we first got the tablet, I didn't realize it, but my eyes were always on it, not on the patient. But I started to get slammed on my patient feedback about being too cold. So I started to put it in my lap with my hand over it so I wouldn't get tempted. And I also do this one other thing which is so interesting and it shows up in my surveys.
What's that?
Remember those patient safety cards we're supposed to hand out?
Yes, the 50 million thing we're asked to do that has no real purpose except to check a box. Hey, I'm not bitter.
I used to think it was ridiculous too to hand out the cards, especially with a negative TV screen. Then somebody else mentioned it and I started seeing the results in my surveys.
What were you seeing?
I had patients say they so appreciated having the information anyway. Their body language changes when you give them something. When I was working at another clinic, they did a qualitative study asking the providers about how their patients responded when they were given the cards. And all the providers almost unanimously used the same word. They said their patients felt empowered. When I talk about the fact that I hand out the cards to all our patients so they can help a friend or someone in their family, they all say thank you and mean it. Like today, I had someone with a negative DV screen, but I gave her the card anyway. She clearly got a little emotional and said she was worried about her sister. Now, was it her sister or was it really for her? And she didn't feel safe disclosing that today. The cool thing is, it really doesn't matter. She got the information either way.
Okay, Obi-Wan. That was good. I was blowing off the cards, not realizing that they get us to the win either way. We so rarely get positives on our DV screening forms, it's easy to forget that there must be lots of folks who don't or can't disclose.
Exactly.
Thank you.
You're buying lunch next time.
Bronwyn, do you want to talk a little bit about our work with Stanford?
Yeah, during the pandemic, we entered a partnership with Stanford Law School's Community Health Access Project, and they've for multiple years now have been doing some really solution-based resource collection and research for us. And they did a state-by-state survey looking for some best practices in this area. And we have a few up here, just a cross-section of the country. In Texas, we do have a law that healthcare providers, when they identify domestic violence, need to make a referral, which is, if you remember the chart, very low level of integration there. And there's no prescription on how they should go about identifying it. So we're really excited to see states like California, Illinois, Ohio, and New York leading the way. And, we're really, excited about the idea of universal screening and universal education.
If you're wondering what kind of screening is there outside of just the one checkbox of do you feel safe at home, guess what? Good news. The CDC has compiled a whole list of every single intimate partner violence and sexual assault assessment tool that exists out there. We use at Texas Advocacy Project a tool out of Johns Hopkins University called the Danger Assessment, which is a great tool. All of our social workers are trained in it. But one of our favorites that is listed in this study is the Domestic Violence Initiative Screening Question. And so once you have somebody who might have said they don't feel safe at home, or their partner, they don't feel safe with their partner, here are some follow-up questions that you can ask. And I want to invite you to remember that making sure that this is done in a really safe way, pulling the abusive partner out of the room, maybe saying that they have to, sign some paperwork or something like that. But these are some of the questions that they have listed. In the last year, has your partner kicked, punched, or otherwise hurt you? In the last year, has your partner put you down, humiliated you, or tried to control you, what you do? We've created, and I was going to pull it up here, but my background's blurred. We have clinic posters that we give to all of our medical legal partners, so that there's lots of places throughout their space that might solicit some of this self-disclosure as well. What we know is that recognition and validation of a survivor's experiences by a healthcare provider increases that survivor's likelihood to exit the abusive situation 2.6 times. Again, remembering you have this really unique time to build relationship and trust and rapport with a survivor. And if you are able to recognize and validate that survivor's experiences and connect them with resources that can help them, it's just, one more way that they can be able to exit those relationships safely. So now let's spend a few minutes talking about our medical legal partnerships.
Yeah, I'd love to share what we've been able to do at Texas Advocacy Project. And really key to what we started doing is right from the beginning, combining legal services with outreach and training. And Amanda would work with the healthcare partners we identified to book out what we like to call a 6-pack of training. And what's nice about packaging it like that is it meant we could come out regularly and help build that relationship. So not only are we building the skills in the healthcare setting, we're building that relationship. So both of those things were happening, building the skills, building the relationship, which drives referrals and warm referrals at that. So this really helped us try to further integrate our care and really truly integrate the care. So I want to drop I'm going to go fast and furious to give you some examples, because you've seen some slides that at the beginning of this presentation, when MLP was defined for you, they shared some different legal needs that people can, legal solutions to medical problems in the healthcare setting. But I want to drill down and be just slightly more specific and talk about intimate partner violence cases. So I have several up here that can give examples for. Safety is the most basic presentation. This could be somebody who says, I'm in an unsafe relationship, or presents with some kind of like broken bone, black eye, bruise, right away you're thinking about their physical safety. Sounds pretty obvious, but related to privacy, we've had cases where a teen has had a nude photo released and now they have suicidal ideations. There's a legal solution for that. We can get an injunction to prevent revenge pornography. So it's not just protective orders to keep abusers away. This is pretty nuanced. From employment, somebody who's experienced sexual harassment might be fired. And then we can work to help them access justice. If they lost insurance, as one thing that would intersect with the medical community, we can help them get coverage back. Under family law, pregnant people who are pregnant because of a sexual assault might be really concerned about their rapist accessing a child. And we have a legal solution for that. We can terminate the father's rights. In the criminal justice system, a victim of intimate partner violence, their parents could miss work to try to take a young victim to the child, to the court, or to their pediatrician. And we can help. There's a legal solution for that. We can help the parent get crime victims compensation for any lost wages from taking off work to help their child victim. There's more in education. We know that people who experience bullying in schools can have all kinds of medical complications, and we have a legal solution for that. We can help get a stay away agreement and make sure the bullying stops in the school environment. What about somebody who is sexually assaulted that doesn't feel safe in their apartment anymore? Maybe they're at the medical care provider to get STD tests or SANE exam. Well, we have a legal solution for them not feeling safe in their apartment. We can help them terminate their lease without any fees. So that would be a reason to call us. I'm going fast, I know. I just want to plant the seed. There are all kinds of legal solutions out there. So bring it home with financial. Sometimes people in an abusive relationship who share children, maybe their partner isn't covering the uninsured medical expenses. So, a child's coming to the pediatrician, some of it's covered by insurance, some of it isn't. There's uninsured medical expenses that should be split between the parents. Abusers might not do that. We have a legal solution for that. We can go to court and enforce that order. And under civil legal liability, you might have a patient with a personal injury claim against their abuser. And we have a legal solution for that. We can help them with the tort case, get compensation for medical expenses. So basically, there's all kinds of legal solutions to medical problems related to intimate partner violence. And then bringing it even to a smaller group of survivors in the perinatal space. We have legal solutions just for this group, for sure. So bringing it back to this perinatal space, good mental, physical, and emotional help is a critical step in healing. So when we partner, we can make sure that our legal assistance is reducing their stress, which can improve your health outcomes. We can help someone with a divorce, not only, closing part of that abusive relationship, but getting them the financial support. What many call alimony, we call spousal support, definitely child support, things like that. Obviously, protective orders can keep somebody safe. You might think it's just a piece of paper. They're actually the #1 way to keep people safe. The Journal of the American Medical Association has reported they're as much as 80% effective. Not 100%, but 80% is actually the best remedy we have, although they're not for everyone. So this is another reason to talk to a legal service provider. So all of these legal solutions can help with medical complications in the perinatal space. And we have a lot of partners, thanks to Amanda over at Texas Advocacy Project. She's made this slide collecting their logos. We really at first cast an even wider net. And then when we decided to hone in on the perinatal space, really that's when the magic started to happen, because there is such a huge overlap. You saw Amanda's statistics, and it's not often you can flip statistics, but we know from what you saw already that if you are experiencing intimate partner violence, you're more likely to become pregnant. And if you're pregnant, you're more likely to experience intimate partner violence. So there's a close kinship between these medical service providers and us as a legal service provider.
Yeah, one of the things that was really important to us was that we have a diverse group of service providers and healthcare providers. So when we were, initially trying to cast the net wide and try to partner with hospital systems, we realized that partnering with people like the Maternal Health Equity Collaborative or Black Mamas ATX and doulas and midwives was really imperative in building those strong relationships, even in-home nursing programs like Family Connects. That's, their service delivery model is similar to how ours is. So integrating within that service delivery model was a little bit easier. So as you guys are in your communities and looking into partnerships, trying to make sure that, again, you're looking at it from that equity lens. Where are survivors accessing services? Who are the trusted healthcare professionals that are providing those? How can you build relationships with them? And how can you integrate within their services?
We're going to share this one case study and then jump into some discussion questions, right, Amanda?
Yes, ma'am.
Okay.
So one of the programs that we have at Texas Advocacy Project that's been around for decades now is called our crisis consultations. So our attorneys go to the jail and they review all of the family violence arrests that have happened the day prior, and we reach out to those survivors. And earlier last year, one of our attorneys had recognized that a survivor, that she had called a survivor who we had helped get a magistrate's order of emergency protection, which is a protective order here in Texas. her abuser was still incarcerated. And she made a referral to our social workers, a Texas Advocacy Project, because she said, this survivor is still pregnant and she has a young child who has disabilities and needs additional resources. And so I worked really closely on this case with our social workers who I was training up a new one at the time. And when I reached out to the survivor, which was 24 hours after the abuse had occurred, she disclosed to me that she was actually in the process of miscarrying. And the miscarriage was a direct result of the physical abuse that she had experienced. And our agency was able to help her. We helped her get the protective order. Our social worker was able to help provide housing assistance for her because she did not work and she wasn't able to pay her rent. And so we were able to provide her with rental assistance. We paid her cell phone bill. And then we connected her with our partners at the Family Connects program and the Central Texas Perinatal Coalition. And that is due to our partnership, our medical legal partnerships. And so we referred back to those healthcare partners who were able to provide assistance for her with her disabled son and able to get him into occupational therapy. They were able to provide her childcare assistance. They were able to provide her healthcare assistance in dealing with the trauma and the medical needs that she had as a result of that miscarriage. And they were able to provide her with food from a local food pantry. And so what is important about these medical legal partnerships, and for us, is we really want to look at mutually beneficial partnerships. Can we refer back to these healthcare providers when we have survivors who also need healthcare assistance as well? And that's been a really key part. And when we look into partnerships, are these mutually beneficial? Can we solicit cross referrals to both agencies? And so we wanted to just give you an example of what medical legal partnership can look like. You can go follow us on any of our socials. We're on Instagram. We are not on TikTok. We are on Instagram and Facebook and LinkedIn and Twitter. This is a quote from a survivor that we served that said, the number one thing that can help a survivor are legal services. And that's what Texas Advocacy Project is. It's the rainbow after the rain. And we want to save the last 15 minutes of our time together to have some discussion questions. Like Bronwyn mentioned at the beginning of this presentation, we are a nonprofit organization, so we never charge for any of our services ever, ever, ever. So if you have your phone out, you can screenshot this little QR code and give us some feedback on our presentation today. We would love to be a resource for you as well. Please feel free to email us or ask us any questions that you might have, but we really do want to spend the last 15 minutes of this cohort to be a collaborative learning space. And so here's some of those questions.
Ones. Yeah. Does anyone have a question on the material that we presented? You're welcome to chat it or raise your little hand. We can jump into some of these while we're waiting for those. I'll go ahead and start with these. I'm really curious how survivors of intimate partner violence are intersecting with your work now. So while you guys think about that question, Amanda, we have a question. Strategies to deal with burnout from being in this work. Man, you don't pull any punches, Lindsay. Look at you.
This is something that Bronwyn and I work really hard on creating a culture of care at Texas Advocacy Project. And so we know that this work that we do is hard. And in the healthcare space and working with our healthcare partners, loving on our healthcare partners also is really important, so that because they're experiencing burnout at really high rates as well. But we have integrated lots of different models within our agency. We have really good time off policies. We really want for our team to take the time that they need when they need it, and to address vicarious trauma, secondary trauma, and hopefully prevent it from happening in the first place. And so ongoing conversations and lots of resources to organizations and therapy outside of work is really important as well.
Bethany raised a good point. We want to hear from you. Who in this cohort has some strategies they can share?
Hi, this is Loral Patchen. I just wanted to share that for myself and providers I work with, I would say that the medical legal partnership itself is an intervention in the healthcare space in terms of preventing burnout. We do all hold a lot in these spaces, and I think the opportunity to feel like there is someone who can follow up and bring legal solutions to some of these environmental and contextual challenges that impact people's health has been, it's been practice changing. And certainly everyone has felt much more engaged in the work of integrating social determinants and really being able to take a step to look at whole people with less fear.
Hey, Nola, I see your hand raised.
Hey, thank you so much for presenting today. I know I'm due in a couple of weeks. I just wanted to say, because of the question number 5, in what ways are social workers utilized to help? By far, I would say that even though my partnership is young, social workers have been absolutely essential to the work that I've been able to do, because I'm a trained attorney. So there are things that I'm good at doing, like paperwork, making phone calls, going over people's heads. But I am not trained to anywhere near the extent that social workers are to coordinate with people to facilitate their care. And particularly, one of the organizations I work with, Family and Children's Services, is able to go with my clients that need it to the Department of Social Services, to appointments, to help them accomplish the tasks that need to be accomplished in order to get done the things that I need them to do. So they're a very important resource for me and for my clients.
I love that. For any of the attorneys that are on this call that work with legal aid offices or in a firm, do y'all have social workers on staff?
Maria, see your hands up. Oh, I can't hear you.
Sorry, I got a lot going on here. I'm Marie Curry at Community Legal Aid. We are in central Northeast Ohio, so south of Cleveland and northeast of Columbus, for those of you thinking about your map. And we do not have a social worker embedded, although we have tried at several times to do that, not in our medical legal partnership, but in our law firm generally, and in our domestic violence practice particularly. Although we would all love and benefit from having a social worker here. I was thinking about your medical legal partnership at TAP and how, you're serving that population, right? That's your population, is survivors, where there are not any of our, we have several different MLP relationships. Some are infant vitality based. So that population is pregnant people and new parents. And sometimes there's a domestic violence issue that we are taking on, but that's not how they're coming to us. Same thing with we have a connection with our children's hospital. So they're coming to us through this partnership that is not related to domestic violence, which I think is similar to what you're saying if you're, have doulas and nurse family practice kind of things. But we hand them off to our legal assistance to victims project. And they help them with whatever's going to happen next, whether it's a civil protection order or a divorce, or maybe they identify something that has to come to some other kind of an attorney, but it's not integrated into the medical legal partnership box, so to speak. Which is a real, is hard. It gets us really experienced practiced attorneys serving our clients, but it doesn't necessarily give us experienced attorneys serving our clients in the MLP model. So there's gaps there.
Right, can I ask you a question? Because do you think, I mean, to me, it seems like there is, but don't you think there's a benefit for the patient client of seeing the consistency of community legal services? Is that the name of where you work? Is it community legal services? Yeah, so they know they're coming to community legal services, and there's different people that work there in the MLP or victim services, but like you have that consistency for them. I feel like that'd be valuable. What do you think?
I do think that it's actually, I think, more valuable to our community partners in some ways. I think that for our clients, they're, they may, depending on what kind of crisis situation they're in, they may see that in a broad way, and they may not. They may still need their community health worker to say, hey, let's reach out to legal aid for that too. But that's a really interesting, we do more outreach and training with our partners than we do with the individual or groups of clients. And that's a really interesting thought to how do we be in that space better? Because it would really empower our clients more, which would be great. Thanks.
Noah made a good point also that so we added social workers onto our team about 2.5 years ago now, at Texas Advocacy Project. And one of the first things that we recognize is that the term social worker oftentimes can be tied with a real negative connotation as that you're going to report me to the system, or that you're going to call CPS and you're a part of that. And so, we've toyed with the idea of changing their title to make it a little bit easier for survivors. But we're really clear in the trainings that we provide, and in the trainings that or the conversations that we have with survivors, is all social workers, everybody in Texas is a mandatory reporter. So even our attorneys are, right? And just because you are living in a home where you're experiencing violence and you're pregnant, now you've had a child, that's not a reason for us to contact CPS. If there's child abuse, neglect, or harm, that's a reason for us to contact CPS. But in Texas, somebody just living in the home isn't reason enough for us to make a CPS report. So we try to be really clear in the messaging of that as we're connecting survivors with social workers, so that they know all of the different things that social workers can do. And then a best practice that we've used is in the cases where we do have to contact CPS, we're really clear with the survivors about what that could look like. And as a mandatory reporter, I don't have to be the one to make a report as long as I know there's been a report that's created, and I want to empower that survivor. And so I tell the survivor, coach that survivor through, okay, listen, this abuse has happened and a report needs to be made. And I'd like for you to be in the driver's seat of that so that you can try to control it a little bit more. And so here's what I'd like for you to do. I'd like for you as the survivor to make the CPS report. And I can be with you while you're making that CPS report. And I can, provide support for you as you're, having to meet with CPS workers and as they're communicating with you. Like, I can be a liaison for you in that, but by the survivor being the one to make that report, seems to, one, empower them, but also gives them a little bit more control in that situation.
Bethany asked a question of the group about getting trainings on trauma-informed care, and I see Kayla is answering it. And if anybody else has suggestions for that. please chime in, like Kayla, thank you.
Brennan, I also see a question from Kayla here. I don't know if you saw it, but they're asking you, as a fellow practitioner in Texas, does TAP accept referrals from other legal service providers?
I think I chatted just back to her some reason, but we love referrals from other legal service providers. It's kind of like jumpstarting our intake process because we know this person's already really been screened and some of their legal needs have been identified. So that's our favorite kind of referral is from one of our partners. And Kayla, we need to connect about that for sure. Thanks for pointing that out, Danielle. Ooh, Holly talks about cross-training. Oh, what a great best practice. If anybody else has evidence of that, please raise your hand or chat it in. But I think that helps build relationships. Holly, do you feel like that's made the relationship stronger? Learning from each other? Are you in a place where you can chat? I don't know.
Yeah, I can. Thanks, Bronwyn. Totally. It's built trust. It's, welcomed the legal team into the clinical setting, I think the trust is the biggest one, because they're both seen as experts in their own field. And I'm specifically talking about sort of the trauma-informed care and, working with really vulnerable populations. A couple of the clinics that we're embedded in are around recovery services, perinatal health, real rural and socioeconomic disadvantaged populations. So yeah, the cross-training has been an aha moment for us as we've continued to go forward.
Well, thank you guys so much. Thank you, Danielle. Thank you, Bethany. Thank you, team. We've enjoyed spending this time together. We'll drop our emails in here. If you guys have any other questions, we'd love to talk through them with you or share our practices and stuff. So yeah, I'll turn it back over to you, Danielle.
Thank you so much, Bronwyn and Amanda, for leading our session today, and to our guest speakers and all of you for an engaging and rich discussion. We do have a very brief survey about today's event that I invite you to participate in. You can either take a photo of the QR code that you see here on the screen or click on the link that the NCEMCH team has shared with you in the chat. It won't take very long to complete, but really help us understand your learning and technical assistance needs, and also help us to improve. Again, thank you everyone for joining us today. It has been a delight to learn from you all. We look forward to seeing you in session 2 of this collaborative, which will be led by Courtney Mendoza at Mental Health Advocacy Services, and will take place on March 8th from 1 to 2:30 p.m. Eastern Time. Goodbye, everyone.